Bismillahirrahmanirrahim. Rabbi shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. So I'm Dr. Mawaddah. So I'm from Universiti Kebangsaan Malaysia, Kuala Lumpur, and today I'll be giving you a half an hour talk on management of glottic carcinoma. Right. So we'll talk a bit about the epidemiology, and then we'll go through the histopathology, basically what you're going to do in the clinic, how you will end up treating the patients, and we'll conclude the topic. So for glottic carcinoma, we know that it is the commonest subsite involved out of all the laryngeal carcinoma. So these are some of the percentages that I managed to get from 3 local publications on laryngeal carcinoma. So we know that it is a disease of the elderly, whereby the mean age of the onset is mainly in the 60s, and with a wide age range between 16 to 82 years old. The risk factors of patients with glottic carcinoma is mainly cigarette smoking, which works synergistically with alcohol consumption. So we know that the main carcinogens from cigarette smoking would include hydrocarbons, nitrosamine, aldehydes, and some occupational related hazards. For example, those who works with asbestos, textile dust, as well as acid mist, in paints and so forth, they tend to get glottic carcinoma too. So the local studies have shown that the majority of the patients were Chinese, and it is mainly a disease of the males, whereby the male to female ratio has been reported up to 11.5% down to 7 to 1. Yeah. So there has been a change in the clinical presentation of the patients, in which now more patients are presenting at the earlier stage. You can see here at this picture, more patients are presenting with symptoms with hoarseness alone. Yeah, we rarely see these clinical pictures nowadays, these clinical findings nowadays, whereby patient present with a fungating tumor from the skin. Yeah? So rarely we see this kind of presentation. So it is good. That means the awareness in terms of early presentation in patients with glottic carcinoma has increased. So the main histologic types in glottic carcinoma is squamous cell carcinoma. It basically occupy about 82 to 87% out of all cases. You can have some adenoid cystic carcinoma. It is rare, still less than 5%, mainly occurring at the subglottis and some at the supraglottis. More rare variants, histological types would include spindle cell carcinoma and also sarcomatoid tumors, and these are rare tumors occurring in the glottis. Yeah. A histologic type that requires special mention is verrucous carcinoma. So verrucous carcinoma was first described by Ackerman in the year 1948. So they present similar to glottic carcinoma, with the main presentation of persistent or progressive hoarseness. But typically on endoscopic finding, you would appreciate a pearly white mass which is hyperkeratotic, and it's fungating out of the epithelium. You can see here, this is a nice 70 degrees view, that you can see that the mass is fungating out of the epithelium. It is pearly white in color. It is hyperkeratotic. So the verrucous carcinoma represents a very well differentiated form of squamous cell carcinoma. One that you need to be wary about is the verrucous carcinoma. It is more radio resistant compared to the conventional squamous cell carcinoma. Hence, you are more inclined to perform some sort of surgery for these patients. Yeah? So you can perform transoral laser microsurgery or even total laryngectomy for advanced tumors. So what is so special about glottic carcinoma? So glottic carcinoma is so special because some may regard glottic carcinoma as a true local tumor. So why I say so? Because the glottis has a lot of embryonic as well as anatomic barriers. So these barriers are natural barriers that prevent spread of the glottic carcinoma to neighboring structures or even distant structures such as the lymph nodes or even distant sites such as the lungs or even the liver. We know for sure that patients with head and neck tumors or head and neck malignancies, distant metastasis to the lung or to the liver occurs following lymphatic spread to the cervical lymph nodes. So embryologically, the glottis has sparse lymphatic drainage. So this is an embryonic barrier to prevent spread of glottic carcinoma. So much so that if you look at this graph here on your right hand side, the percentage of pooled incidence of occult metastasis in glottic carcinoma is roughly about 8%. So much so that the incidence is so low that an elective neck dissection is not indicated in these tumors. But if you look at other subsites, for example, the supraglottis, or if you do not specify the subsite, and in cases whereby it's T3 to T4, you can see that the pooled incidence of occult metastasis start to raise even more than 20%. So in these patients, these subgroup of patients, they may require elective neck dissection. So this gives you evidence and confidence that you can treat the local tumor at the glottis without being have to worry about any lymphatic spread to the cervical lymph nodes. Yeah? So the glottis also has a lot of anatomical barriers. So these anatomical barriers are in the form of fibrous barriers as well as cartilaginous barriers. So there are submucosal elastic layers within the larynx itself that prevent spread of the glottic cancer. So this would include the conus elasticus inferiorly, then the quadrangular membrane superiorly, preventing spread to the paraglottic space, the Broyles ligament anteriorly, preventing spread to the thyroid cartilage. But if the Broyles ligament is involved with the tumor, it may facilitate spread of tumor to the thyroid cartilage itself. So the hyoepiglottic ligament prevents spread of the glottic carcinoma to the pre-epiglottic space. The glossoepiglottic ligament prevents spread of the glottic carcinoma to the tongue base. So there you are, you've got many submucosal elastic layers preventing spread of the glottic carcinoma. We also have cartilaginous barriers such as the thyroid cartilage, the cricoid cartilage, the arytenoid cartilage, the epiglottis that prevents spread of glottic carcinoma extralaryngally. Hence, it is something that you may think gives you more rationale to treat glottic carcinoma in a local context. So what do you do? How do you evaluate your patients in the clinic? Of course, it includes a comprehensive history and physical examination. Most of the time, the patient will present with a persistent or progressive hoarseness, which spans more than 2 weeks. In the early stage, it may not be associated with other symptoms. You may want to elicit whether the patient has other functions affected. This one is the function of phonation. You want to see whether the patient has airway compromise or not, whether the patient has stridor, whether there's reduced effort tolerance, whether the patient can protect the airway from aspiration. That's a very important point. You want to be assessing the functions of the larynx. Then you may want to ask yourself this question: what are the factors that may affect the treatment that you want to institute? So you want to ask the patient about their vocal demand. What is their nature of work? What kind of profession do they work as? What are the risk factors? You may want to consider this, because if the patient has early stage tumors and the patient do not stop smoking, then the patient is at risk of developing residuals and recurrence. It's very important for you to advise the patient. Yeah. So you also need to do a neck examination, especially if the patient has a big tumor. You want to see if there's any suspicion of extralaryngeal spread. You want to do a complete laryngeal examination and a cranial nerve examination. So we often do clinic endoscopy, and in a case of a patient with glottic carcinoma, this clinic endoscopy is your opportunity to really examine the extension of the tumor. So you want to be really close to the vocal folds, and therefore you may want to consider giving additional anesthesia, such as giving a laryngeal gargle, or even giving intratracheal anesthesia for you to have a closer view if you can't visualize certain areas. So you may want to have a particular attention to examine the anterior commissure, the supraglottis, subglottis. You want to see whether this lesion is unifocal or multifocal. You want to see the lateral extension. Is the ventricles involved? Um, if you can see two mass, are these mass in continuity? And you also want to differentiate whether it is an early or an advanced disease. And you have to try to be able to describe the mass really well with regards to the extension and also the nature of the mass, whether it is a fungating or an ulcerative mass. So this is an example of a clinic endoscopy which is done for a patient who presents with tumor fibrosis. So we give laryngeal gargle in our clinic, and here you can see that there is involvement of the anterior commissure here. So the tumor doesn't involve the laryngeal surface of the epiglottis, and you can see clearly that the subglottic area is normal. So giving a laryngeal gargle will certainly be advantageous. You can see the tumor extent and allow planning of the patient whether you want to consider CT scan or imaging and its indications in patients with glottic carcinoma. So there are two reasons why we perform imaging in a patient with glottic carcinoma. Number one is for staging and prognostication. Your by the time now, you all will know that we stage patients with glottic carcinoma using the TNM classification. So involvement of the thyroid cartilage, paraglottic space, pre-epiglottic space, these are all significant areas that would suggest a poorer prognosis in our patients. And of course, I would also want to see involvement of therapeutic significance. Certain anatomical involvement would tell me that I can't do certain surgeries for patients with glottic carcinoma. For example, if you have major erosion of the thyroid cartilage, these may not be amenable for organ preservation surgery. So you may want to skip and do total laryngectomy, even though the patient has a functioning larynx. Involvement of the arytenoid is also not a suitable for patients if, let's say, the patient is to undergo transoral laser microsurgery. So you may want to consider other things such as supracricoid laryngectomy. Involvement of the posterior paraglottic space. This one, transoral laser microsurgery or open partial laryngectomy is contraindicated. So if you have a patient such as this, you have a tumor seen on the left vocal fold involving the anterior commissure, you can't see the anterior extension really well, you're considering to perform a CT scan in this patient. So CT scan is a good primary modality of radiological investigation in patients with glottic carcinoma. So the type of CT scan that you want to request is a thin sliced CT. It has to be 1 millimeter cut or less. So it can't be a thick sliced CT. Why? Because the larynx itself is not very thick. The glottis is only 1 centimeter in thickness. So you might miss certain things if you were to do a thick sliced CT. So this is an example of a patient whom we missed thyroid cartilage erosion on a thick cut CT. So this was a thick cut CT. You see a nice thyroid cartilage, nice paraglottic space, no involvement of the arytenoid cartilage. But if the imaging is revisited on a thin slice CT, you would see that there is major erosion of the thyroid cartilage. So this patient is T4A instead of just a T2. So these are other examples of imaging findings in a patient with glottic carcinoma. Here you can see involvement of the posterior part of the paraglottic space. So the paraglottic space is to appear like this, black in color. If it's filled up, it looks kind of like hazy, kind of gray then. So there is involvement of the paraglottic space here, and there's displaced space, there's increased space between the arytenoid and the thyroid cartilage, posterior paraglottic space involvement. So in this image here, you can see that the paraglottic space is effaced, but there is still clear plane with the thyroid cartilage. So there is no erosion of the inner pericardium of the thyroid cartilage. Yeah? Another image showing involvement of the paraglottic space both anteriorly as well as posteriorly, with increased distance between the arytenoid and the thyroid cartilage. And here you can see sclerosis of the arytenoid cartilage and sclerosis of the cricoid cartilage here, cricoid ring here, cricoid cartilage signifying involvement of the cricoid cartilage. And here you can see sclerosis of the arytenoid cartilage, which is a contraindication of transoral laser microsurgery. If you are in doubt, based on your clinical examination, you don't suspect involvement of the cartilage, but if you do an imaging and it tells you that there is involvement of the cartilage, you do CT scan, the radiologist say that there's involvement of the cartilage, then you might want to confirm with an MRI because it tells you cartilaginous involvement better than the CT scan. So not all patients with glottic carcinoma need imaging. Only a certain group of patients need. For example, these patients would include patients with anterior commissure tumors, the tumors that you can't see the lateral margins, have reduced vocal fold mobility, posterior extension to the vocal process if you have suspected extralaryngeal spread, suspected nodal disease, or suspected metastatic disease. Yeah. Indications for metastatic workup is very institutional based. For our center, we perform HRCT thorax if you have a high end laryngeal tumors, for example N2 or N3 laryngeal cancer. You have an abnormal chest x-ray. PET CT scan we don't normally do for pre-treatment because we know that glottic carcinoma, most of the time it is a local disease, hence the turn over time for the cells are low and they tend to be less metabolic, so the SUV will be low. But it is very much utilized in patients with suspected distant metastasis or in a patient with recurrent laryngeal cancer. So the students asked a lot about this, establishing a tissue diagnosis in glottic carcinoma. How do you go by? So this is a standard of care. We perform direct laryngoscopy and biopsy for all patients. It allows three-dimensional evaluation for tumor extent. We can use the angled telescope and see the hidden areas like the anterior commissure, ventricle, subglottis. We are able to palpate the tumor to ascertain the origin. We can use enhanced imaging if you have this for tumor mapping. We perform hydrodissection to see whether the vocal ligament is involved or not, so that we can see the depth of invasion. Most of the time, I would consider imaging prior to direct laryngoscopy and biopsy because the direct laryngoscopy and biopsy itself may cause edema and inflammation. So if you were to do the CT scan after direct laryngoscopy and biopsy, you would overestimate the extension of the tumor. So the type of biopsy performed in a direct laryngoscopy and biopsy for patients with glottic carcinoma, it depends on the tumor appearance, extent. That is based on your best guess on your endoscopic examination as well as the CT scan. And you must evaluate the patient's values. Yeah? So for example, if you have a single tumor like this, it's of course juicy and you can attempt to perform excision biopsy. But if you have a multifocal tumor like this, so you might think, this one, I can't perform transoral laser microsurgery, so you can't perform diagnostic and therapeutic at the same time. You may want to perform punch biopsy at multiple sites. So you have an ulcerative tumor, you may want to perform incision biopsy. You want to make a deep biopsy so that you can get good yield for the patient. Yeah. So treatment in glottic carcinoma, early glottic carcinoma in a functioning larynx, that means the patient doesn't have upper airway obstruction, is able to protect his or her own airway. The staging is T1, T2, and select all small cases of T3 and 0. The treatment modality is single modality. Remember this. So you can't perform surgery if you think that you need to do radiation after the surgery. Don't do that. It's a single modality treatment. you choose either radiation or surgery. The surgery would include open partial laryngectomy, transoral laser microsurgery, or transoral robotic surgery. We don't have this in our center. So radiation is not a wide field radiation. It's not like nasopharyngeal carcinoma radiation. It's a small rectangular field radiation, about 5 by 4 centimeter, mainly anterior field, no lateral fields at all, because you don't need to radiate the neck. Remember, we've talked about the incidence of nodal metastasis. It is very low. So the rationale of transoral laser microsurgery, there are many, but you have to remember that it is operator dependent. You need trained surgeons, and you also need pathologic evaluation of the margin status. So I put this up because seems to be a lot of confusion about the different types of cordectomy. So this is the most recent one that I can find. It is based on this textbook by Dr. Manuel et al., published in 2016. So in most cases, we perform type 1 cordectomy for diagnostic purposes. But if the patient agrees, you can perform even up to type 3 cordectomy for diagnostic purpose, so that you don't need to revisit the surgery. For example, the patient has multiple comorbidities, is elderly, and the patient prefers to have one surgery in treat the tumor in the same setting as biopsy. So you may want to read about these different types of cordectomy, and so that you are able to classify the surgery according to what you have removed. Decision making in early glottic carcinoma takes into consideration the best scientific evidence, clinical experience, as well as the patient values. So the clinical experience is what is the better treatment that you have available in your institution. So it's talking about your audit. So in your hands, what would give better outcomes in terms of oncologically, functionally, and as well as the complications. So for example, I don't have much experience performing supracricoid laryngectomy, so I can't offer this to my patients really well. I may want to refer the patients out. And if you talk about clinical experience, so the best treatment should allow more options for salvage treatment. So if you talk about radiation, you can't undergo radiation twice in your lifetime. So that is a less better option if you talk about allowing more options for salvage treatment. So best scientific evidence is regarding the pooled incidences of basically recurrence, residuals, complications, local control rates, and overall survival. So these are real world data. So you evaluate this and offer the patients based on these best scientific evidence. So for transoral laser microsurgery, we need to do a proper operative evaluation. So the video will show you the kind of operative evaluation that we perform for the patients. Showing our evaluation of a
Ayah
patient
dan
with
mak
glottic
tinggal di
carcinoma.
bandar.
We take a
Abang
voice
dan adik
recording of the
saya tinggal di
patient.
bandar bersama ayah dan
You
mak.
can hear that this
Setiap
patient's voice
minggu
is quite
saya dan
good,
nenek
and
Okey.
the main problem is with roughness for this patient. So we perform close examination of the vocal fold, as I've mentioned earlier on. See whether there's involvement of the ventricles or not. So in this case, there's no involvement of the ventricles, no subglottic involvement, so the patient did not require a CT scan. So this is close examination in the OT. So you examine closely the anterior commissure, is it involved or not. So here we are rolling the vocal fold to see the inferior extension of the tumor. Vocal fold injection, you want to hydrodissect and see here this tumor is raised from the vocal ligament. So this tells us that the tumor doesn't involve the vocal ligament. So the margin for transoral laser microsurgery is 1 millimeter. So you want to be able to preserve normal vibratory structures of the vocal fold. So preserve more and you have a better voice outcome. So this is how we remove the tumor by transoral laser microsurgery. So at the end of the surgery, it looks like this. So this patient underwent a type 2 subligamentous cordectomy. So it doesn't mean that for a microinvasive cancer, you need to do minimum type 3 or type 4. So it depends on the tumor extension. Piecemeal removal of the glottic carcinoma. So in this technique, you need to mark the margins of the tumor. Yeah. After you've marked the margins of the tumor, what you need to do is you need to bisect the tumor at the midpoints. So this allows you to examine the margin or the deeper margin of the tumor. So as you all know, if you cut using laser, you will be charred. So, but if you cut normal tissue, there won't be much charring. So use this to gauge the deep extension of the tumor and remove the posterior bit of the tumor first. Then you can remove the anterior part of the tumor. So removing the posterior part of the tumor in piecemeal allows you better retraction of the and better, you'll be able to manipulate the tumor better in order for you to deliver the anterior part of the tumor and ensure a good margin status for your patients. Okay. So now let's talk about open partial laryngectomy. Basic principles, the patients need to have a good lung reserve. You need to have at least one functioning cricoarytenoid unit. Yeah, so it must be normal. It must be able to abduct, it must be able to adduct, and radiologically there is no involvement of the cricoid cartilage or the arytenoid cartilage on that side that you want to preserve. So the contraindications include large T3 or T4, or there's subglottic extension. The extent of the subglottic extension may be variable between centers. Some say 0.5, some say 1 centimeter. Yeah. So there are three basic types: supraglottic laryngectomy, vertical partial laryngectomy, and supracricoid laryngectomy. So vertical partial laryngectomy is the one that is mostly utilized. Yeah, even though we have done only two in our center, but if you look at other centers, especially in Perlis, have done quite a bit. There are two types: the frontal type, which means resection of the V portion here to resect anterior part of the larynx. Anterior commissure is gone, both right and left side. Anterior third of the vocal fold is gone, and you can resect the anterior part of the paraglottic space if, let's say, you perform a frontolateral type vertical partial laryngectomy. Um, but the posterior part of the paraglottic space, you can't really resect using this surgical technique. Yeah. So you need to have frozen section and consent for total laryngectomy for all patients who undergoes a vertical partial laryngectomy. Should the frozen sections are involved, you can't preserve one cricoarytenoid unit. You need to perform total laryngectomy in these patients. So reconstruction is achieved by using either the strap muscles or remnants of the outer perichondrium. So what about supracricoid laryngectomy? I've never done this, but essentially it entails removing the airway above the level of the cricoid cartilage. Yeah? You can either preserve or remove the epiglottis depending on the involvement of the preepiglottic space. So if the preepiglottic space is removed, you need to reconstruct using cricohyoidopexy, so proximate hyoid to the cricoid. But if it's not involved, you get to preserve the epiglottis and you can perform cricohyoidoepiglottopexy. Yeah. Okay, for large volumes T3 and T4A, the main treatment is a combined modality treatment in which you need to perform total laryngectomy, elective neck dissection, plus minus hemithyroidectomy with adjuvant radiation. These are the main treatment options. But in certain centers, based on your institution, you may want to discuss with the oncologist. This is what we do in our center. We do not give adjuvant radiation for select T3 and 0M0 patients without adverse features. So these are the patients with negative margin status, no lymphovascular infiltration, no perineural spread, um, the lymphatic involvement is small. If you have a single node involvement less than 1.5 centimeter, no extra capsular spread, you can skip giving adjuvant radiation, but you have to closely follow the patients up. So the surveillance visit in our center would include monthly visit for the first 6 months, and then the subsequent 6 months is 2 monthly. That finishes off the first year. On the second year, the patients receive 3 monthly visits. On the third, fourth, and fifth year, it's a 6 monthly visit. Yeah. Okay, so essentially we are looking for new symptoms and new signs. You have to keep in mind your treatment may have caused scarring. So if you see something is bulging, it raises a suspicion of a recurrent disease. So in conclusion, a treatment or management of glottic carcinoma is always a balance between preserving residual function and providing oncologic clearance. And treatment decision considers best scientific evidence, pooled data overall, real world data, clinical experience, what you can offer, and patient values in a multidisciplinary setting. So certain patients, they don't like surgery, so you can't offer them surgery. Yeah? Certain patients are not fit for surgery, so you have to consider all these in your treatment decision. So with that, I would like to thank you, and I would like to wish you all the best.